Hello and good morning everyone. As a part of continuous cardiac education, our topic of discussion today is endovascular management of acute limb ischemia, which will be presented by Dr. Hashit Joshi sir, who is professor in the field of cardiology at UN Mehta Hospital, having more than 24 years of experience in the field of interventional cardiology. Looking forward to your kind presence. Thank you.
Today's topic is acute limb ischemia. Acute limb ischemia represents a clinical emergency with potential limb loss and life-threatening consequences. It is characterized by a sudden decrease in limb perfusion. Acute ischemia is defined as by a duration of less than 14 days. Immediate diagnosis, accurate assessment, and urgent intervention is needed for limb salvage. Aging of the population increased the prevalence of this limb ischemia. The incidence is 1.5 per 10,000 people population. Major amputation after ALI ranges between 10 to 15%, and 30-day mortality due to this is around 15 to 25%. ALI is sudden deterioration of arterial supply to the limb. The two principal etiologies are embolization and arterial embolism and in situ thrombosis. In situ thrombosis accounts for about 60% of cases, while arterial embolization accounts for about 30% causes. Very rare are thrombosis of popliteal aneurysm, trauma, and iatrogenic. Now, thrombosis. In situ thrombosis occurs in diseased local arterial segment with prior atherosclerosis, stimulating the formation of collateral channels. Acute occlusion with thrombus occurs from plaque rupture or low flow states or hypercoagulable states. This also includes thrombosis into previously stented segments or vascular grafts. Sudden arterial plaque rupture also accounts for thrombosis. Other common causes of thrombosis are trauma, external compression, iatrogenic, which is more common nowadays with puncture or dissections, arterial dissection, arteriopathy, arthritis with thrombosis, and adventitial cyst or entrapment symptoms. Now, cardiac emboli are most common, causing 80% of the embolic things. It can arise from mainly with atrial associated with LA appendage clot in atrial fibrillation or mural thrombi in case of a recent myocardial infarction, endocarditic vegetations, and atrial myxoma as possible underlying causes. Aneurysmal disease segment and proximal atherosclerotic debris are another cause of potential embolic sources. Less frequent are air, fat, or amniotic fluid embolism or paradoxical embolism. Now, there are few clinical markers which can help us define whether it is embolism or thrombosis, because thrombosis is on a stenosed calcified vessel. There is some amount of collateral circulation, and hence there is some symptoms of chronic ischemia. While embolic is very often very sudden, the source of embolism can frequently be detected by a echocardiography or transesophageal echocardiography. Onset of embolism is sudden, while thrombosis can be acute, not that sudden. Previous history may be helpful in both. Findings: normal pulses in unaffected limb in a case of embolism, while in thrombosis there is evidence of PVD in other vessels also. Embolic phenomena can occur at multiple sites, while thrombosis usually is a single site, and angiography shows multiple occlusions in embolism with no collaterals, while diffuse atherosclerosis, and collaterals present in thrombosis. However, this does not make much more difference in management. Now the pathophysiology, there is a syndrome MNMS, that is myonephropathic metabolic syndrome, which occurs during prolonged ischemia. Due to this, there is insufficient oxygenated blood to meet metabolic demands of tissue, which leads to anaerobic metabolism, lactate production, depletion of ATP, and leakage of extracellular calcium into muscle cells, cell death. And this leads to overproduction of lactate at the site, which leaks into the blood and causes hyperkalemia, lactic acidosis, and other metabolic events. The severity depends on degree of obstruction, site of occlusion, presence of collaterals, affected tissues, and systemic perfusion such as cardiac output and peripheral vascular resistance. Now, different tissues are differently sensitive to ischemia. With time, peripheral nerves irreversible damage occurs between 2.5 to 6 hours, while skin and skeletal muscles are most resistant to ischemia and can tolerate ischemia up to 10 to 12 hours. Now, the classical symptoms, characteristic physical findings of ALI are 5 P's, that is pain, pallor, pulselessness, paresthesia, and paralysis. First two, pain and pallor, that is an area of fixed cyanosis surrounded by reversible mottling, empty veins compared to normal limb. Compressing capillary return is delayed. The limb is cold on touch as compared to the other, and you can find a demarcation line. Pulselessness, sudden loss of previously palpable pulse, low capillary refilling after finger pressure, and bounding water hammer pulse proximal to the occlusion. Paresthesia, loss of sensory function, numbness will progress to anesthesia. Progress of sensory loss, light touch is lost first, then vibration, proprioception, and then deep pain and pressure sense. And paralysis is the last stage where fine movements are affected first. Loss of motor function indicates advanced limb threatening ischemia, and late irreversible ischemia is seen by muscle turgidity. Now, evaluation and diagnosis of ALI is primary clinical. The severity of ALI, in suspected ALI, initial clinical evaluation should rapidly assess limb viability and potential for limb salvage. The severity of ALI is classified according to the Task 2 and Rutherford classification into 4 groups, and they are classified according to sensory disturbance, muscle weakness, and Doppler assessment. This is the Rutherford classification, where class 1 is viable, where the limb is not immediately threatened, sensory loss there is none, muscle weakness there is none, and Doppler signals in both arterial and venous sides are audible. Class 2 is divided into threatened limb, which is A and B. A is marginally threatened, where it is salvageable if promptly treated or emergency treated. There is minimal sensory loss, no muscle weakness, inaudible arterial Doppler signals, however venous signals are audible. Class 2B, salvageable with immediate or urgent revascularization. More than toes sensory loss is there and associated with rest pain. There is mild to moderate muscle weakness. Arterial Doppler signals are inaudible, however the venous signals are still audible. And class 3 is irreversible, where major tissue loss or permanent nerve damage has already occurred. There is severe sensory loss, or there is loss of pain. There is profound paralysis or muscle weakness, or a foot drop which is very suggestive of class 3 Rutherford limb ischemia. There is inaudible arterial and venous Doppler signals. Now for further, ALI is a clinical diagnosis and further investigations are carried out to confirm etiology and level location of occlusion and to plan the therapeutic approach and the access site. Before imaging modalities, to identify the cause and evaluate the general health of the patient, an electrocardiogram, blood count, biochemistry, coagulation profile, protein C and protein S, anticardiolipin antibodies, antithrombin 2, urinary analysis, ABG, serum CPK plane, serum potassium, and echo TE are performed at baseline. Now, imaging modalities for the lesion specific include duplex ultrasound, which is done at the baseline, CT angiogram, DSA, and MR angiogram. Invasive angiogram, DSA, was considered the gold standard, but lesser invasive like CT angiography, duplex angiogram, and MR angiogram have emerged, and now invasive angiogram remains only when therapeutic intervention is planned. CT angiography, it is non-invasive, arterial puncture is not there, accurate location of analysis of location, extent, and grading of steno-occlusive disease. It can differentiate to some amount embolic and thrombotic causes. Conditions of vessels can be visualized and distal arterial tree is visible. Disadvantage is ionizing radiation, and in renal failure, which is present in many of these patients, it is harmful. And stenosis beyond calcium, if it is very calcific, stenosis cannot be graded accurately. Duplex ultrasonography should be the first thing. However, it is operator dependent and fairly accurate for infrainguinal disease, especially for bypass graft, but suprainguinal arterial occlusion and distal runoff vessels are not well visualized. Calcification also can cause artifacts. DSA is now only for intervention. MR angiogram, it is less contrast load than angiography, non-ionizing. Distal vessels and pedal vessels can be seen well as compared to CT angiography. However, time, higher cost, and large number of artifacts, and it is more time consuming than CT, and not available very readily. So now coming on to treatment of ALI, main target is rapid restoration of arterial flow with least risk to the present, and it need not be done by a single discipline. It can be multidisciplinary. It involves interventional cardiologists or radiologists, surgical or vascular surgeons, and intensivists, all in tandem to manage the patient. Revascularization can range from CDT to surgical thromboembolectomy. Selection of intervention, again the one which provides the most rapid restoration of arterial flow with least risk to present. Prolonged duration of ischemia, more than 8 hours, is the most common factors of patient requiring amputation for treatment of ALI. So our aim is limb salvage at the best. Now the first treatment for this is heparinization. The first step in ALI management is immediate anticoagulation with heparin. It was first introduced in 1975 by Blendell et al. To prevent proximal and distal propagation of the thrombus. It does not lyse the established thrombus, however, it prevents the thrombus propagation into the collateral vessels and proximal and distal. IV unfractionated heparin 80 units per kg, 50 to 100 depending on the patient, followed by an infusion 18 unit per kilogram per hour, and APTT is to maintain between ratio 2 to 3. Known case of heat or antithrombin 3 deficiency, alternative agents like direct thrombin inhibitors can be used. Low molecular weight heparin or fondaparinux can be substituted for heparin in all patients. Other measures: adequate analgesia, IV fluid resuscitation, urine output monitoring, oxygen supplementation, correction of underlying electrolyte imbalance. Antiplatelets, dual antiplatelets are a standard therapy at our institute. Limb placed in dependent position and kept warm, and limb management. Now this is the algorithm: acute limb ischemia, heparin and pain management. Then if it is Rutherford class 1, initial workup. Here we can take some time, and revascularization within hours. Class 2, urgent revascularization depending on whether vascular lesion, whether it is present or not, or absent, endovascular, and if it is irreversible, Rutherford class 3, amputation is the only thing that should be done, and attempts at revascularization may still be more detrimental. However, medical follow-up even after amputation is necessary, because if patient had embolism or even thrombosis, he can have recurrent emboli or thrombus at other places. Now, class 1 ALI may require only medical therapy such as anticoagulation at present. Revascularization, if contemplated, can be performed electively, can be either thrombolytic or open surgical intervention depending on duration of ALI, location and cause, presence and absence of underlying PVD, and patient's general medical condition. Class 2A requires flexible approach to intervention. Urgent revascularization within 12 hours is necessary. Duration of symptoms is of prime importance. Now, percutaneous endovascular options are more effective in patients with ischemia less than 2 weeks duration, and more than 2 weeks duration are better served by surgical revascularization. Prospective studies comparing thrombolytic and surgical intervention favor the initial use of thrombolytic therapy. However, at 30 days the difference was not much, and a combined approach also can be done. Surgical intervention reserved in patient unresponsive to lytic therapy. Class 2B, where requires emergency revascularization within 2 to 6 hours. Here surgical revascularization is preferred. However, advances in CDT and thrombosuction devices have shortened the time for reperfusion, and either techniques can be used as first line therapy in patients with class 2B ALI. Class 3 ALI, amputation should be considered, and intensivist reference for management of acidosis and hyperkalemia and to prevent MNMS syndrome should be done. Now, coming to surgical revascularization, balloon catheter thrombectomy, first introduced by Fogarty in 1963, has been cornerstone of therapy of surgical management of ALI. And this is the therapy of choice. There are different sizes of balloon which are available, and these were initially not wire based. However, recently a trial with wire based Fogarty catheter, so that an additional endovascular therapy, if required, can be performed after Fogarty, has been done, and the trials have been reasonably good. Interventional option, CDT, catheter directed thrombolysis, pharmacomechanical thrombolysis, mechanical thrombectomy with or without thrombolysis, and now balloon catheter thrombectomy. It can be done with local or general anesthesia, proximal artery, larger artery exposed and held in slings with longitudinal or transverse incision. Focarty balloon catheter is introduced past the occlusion, inflated and withdrawn with the clot. Good back bleed and antegrade bleeding suggests that the entire clot has been removed, and a completion angiography is required to ascertain adequacy. Advantages: it is rapid revascularization, transfemoral approach can be done via local anesthesia, and adjunct use of intraoperative thrombolysis also can be done. However, because it is not wire based, that there is chance of vessel injury and more chances of reperfusion injury and compartment syndrome, and mutilative local site is there. Bypass procedures are commonly performed in patients after failed balloon thrombectomy as a last resort and extensive tissue injury and associated peripheral vascular disease. If good targets are there of if feasible, a femoropopliteal or femorotibial bypass are salvage procedures. However, long-term graft patency are doubtful, and a venous graft should be used instead of Dacron graft. Now, coming to interventional catheter directed thrombolysis, the goal is to achieve regional thrombus dissolution with minimal systemic fibrinolysis. If access is not that, peripheral fibrinolysis also can be done. However, this is less effective, and a local clot directed thrombolysis is better. It is preferred treatment in class 1 and 2A, ALI less than 2 weeks, and acutely thrombosed grafts and occluded stents. Advantage is direct delivery of drug into existing thrombus, reduces thrombolytic drug doses, lyses clot both in large and small vessels, lower incidence of reperfusion syndrome, and minimally invasive. Disadvantage is it takes long time, more than 24 hours to be effective, and the risk of major bleeding are about 6 to 9%. The checklist for any thrombolysis is to be kept there. Contraindications, absolute contraindications: cerebrovascular events before 2 months, within last 2 months, active bleeding thyroiditis, recent GI bleeding, neurosurgery, intracranial trauma. Relative contraindications: non-vascular surgery or trauma less than 10 days, CPR, uncontrolled hypertension, non-compressible vessel, recent eye surgery. And minor contraindications: hepatic failure, bacterial endocarditis, pregnancy, diabetic hemorrhagic retinopathy, and LV and LA clot also are relative contraindications. The following protocols are recommended: weight adapted administration of altiplase 0.001 to 0.02 mg per kilogram per hour, or non-weight based altiplase of 0.12 to 2 mg per hour, maximum dose 40 mg. In both scenario, additional low dose intraarterial heparin 400 to 600 IU per hour to avoid new thrombus formation. For atiplase 0.25 to 1 mg per hour, maximum dose 20 IU in 24 hours, or low dose regimen 0.125 mg per hour. Tenecteplase can be administered as a bolus infusion of 1 to 5 mg, followed by infusion ranging from 0.125 to 0.5 mg per hour. Urokinase 3 legs in first hour, followed by 1 leg unit per hour over 24 to 48 hours. Pharmacomechanical thrombectomy. Several mechanical clot removal devices are used in adjunct with nitric agents. It could be ultrasound, power pulse, used to accelerate the speed of thrombolysis, decrease the dose of lytic agents and duration of thrombolysis. Now, echoes, where a sonographic ultrasound is used to facilitate clot penetration by the lytic agent. This is due to thrombus formation by ultrasound, deformation by the ultrasound wave, which exposes a great surface area into infused lytic agent. Clinical success rate is 90% in some studies. Angiojet thrombectomy system, it has longest clinical history. It is using the hydrotherapy as a mechanical lysing agent and has catheter pump set and drive unit. Pump and drive unit provides high velocity saline jet that is redirected at the tip of dual lumen catheter. Saline solution from pump drive is driven at 50 to 60 ml per minute and at 8,000 to 10,000 pounds per square inch, resulting in high velocity jet at the catheter tip. Thrombus surrounding the catheter tip is fragmented and rapidly evacuated by the effluent lumen. Disrupts thrombus, allows better penetration of clot by a thrombolytic agent, reduces thrombolytic dosing, reduces therapy time, increasingly being used in class 2B, done via percutaneous approach and local anesthesia, less vessel injury. However, can be used only in large vessel and expensive device. Angiojet, now instead of the saline, there are rotational and mechanical devices also used. Rotational thrombectomy system by Argon Medical and Trio Rotola system by Teleflex. This is more used in dialysis, excess graft occlusion. Native vessel, they are less used because rapid 40,000 rotations per minute spiral is used, which can cause some injury to the native arteries, and risk of distal embolization of microparticles of thrombus are there. Rapidly rotating spirals creates a Venturi effect, and there is a negative suction attached to the same, which can suck the thrombus. Now there are thrombus aspiration devices like Diverse or Aspire Max mechanical thrombectomy system, as we are using in acute MI also. The size of the thrombus fragment can be aspirated is limited by the distal diameter of the catheter tip. It is available in 6 to 8 French size. It is very useful when small amount of fresh thrombus are there in distal and small vessels, and to treat embolization after a recent angioplasty. However, it has low success rate when used as standalone therapy only. In vitro studies comparing endothelial denudation with angiojet and Fogarty thrombectomy catheter have demonstrated greater mean endothelial loss in vessels treated with Fogarty. So angiojet is now gaining more and more evidence in class 2A and 2B Rutherford. These are the trials with angiojet, echoes and mechanical thrombectomy. Dutch randomized trial, echoes with standard CDT. No difference in technical success. However, time to achieve complete lysis and overall lytic dose were significantly less in ultrasound accelerated thrombolysis group. So these are the algorithms for hybrid procedure and operative thromboembolectomy with thrombolytic therapy or incomplete thrombus extraction with small bolus plus repeat dosage, extensive thrombosis, high dose isolated limb perfusion can be done. Reverse also can be done. Intraoperative thrombolysis also can be done. Amputation, performed as a first index procedure in non-salvageable class 3 limb and low potential for limb salvage. Amputation mortality and long-term limb salvage in open surgeries from in ALI. Mortality is about 22%, 10% and 25%, and limb salvage is about 62 to 75%. Thank you.